This is just a really brief presentation about celiac disease screening for psychiatrists, and specifically in integrative psychiatry because we think about, the whole body and the impact of nutrients and inflammation and those types of things in our patients with mental health disorders. So we're just going to quickly review the celiac disease pathophys and symptoms, why certain psychiatric patients should be screened for celiac disease, how to screen for it, and how to interpret results. So celiac disease affects 1 in 100 in the US. It's that's larger than I would have thought initially for people who actually really have celiac disease. And many times celiac disease goes undiagnosed, and it can go undiagnosed even for decades. It's defined as a chronic condition. It's an autoimmune condition, and basically what happens is that gluten will come into the intestine and trigger an inflammatory cascade that will then turn into the destruction of the patient's villi. And I'll show you a little slide, but basically the destruction of the villi means that nutrient absorption is very low depending on the extent of the destruction. So the more it's been wiped out, the less surface area there is for absorption of nutrients and the more inflammation. And so then things get in that shouldn't, and things that should get in don't get in as a result of basically creating a malabsorptive condition. There are lots of manifestations of celiac disease, not just the typical weight loss and anemia and diarrhea picture, and we'll talk about that in a moment. It is important to note that actually the majority of celiac disease patients do not have the typical intestinal symptoms. So this is the histopathology of this. So looking at the normal villi on the left there's lots of nice surface areas in these crypts for the nutrients to come in and to be absorbed. And when you have widespread inflammation, you can see lots of inflammatory changes and way reduced surface area as well for the absorption of nutrients. So there are considered to be typical symptoms and atypical symptoms of celiac disease. The typical ones, like I mentioned, are abdominal pain, bloating and gas, diarrhea, foul-smelling stools, weight loss, poor growth or weight loss in kids, anemia. And the atypical symptoms are more vague in nature: weakness, constipation, fatigue, low iron, calcium, folate, and B12 also is low sometimes. Bone and joint pains, arthralgias, osteoporosis. Even in kids, there's a significant percentage of kids when they get a celiac diagnosis, they already have osteopenia, if not osteoporosis. Skin rash, that's the typical dermatitis herpetiformis rash, and fertility issues ranging from recurrent pregnancy loss to low birth weight, and lots of other obstetrical complications. Neuropathy, including unexplained peripheral neuropathy, and depression and anxiety are considered to be atypical symptoms as well of celiac disease. So the extraintestinal manifestations are what we psychiatrists would probably focus on more, because a lot of times the people that have had the typical manifestations are, going to their primary care doctor, and in my experience, a lot of PCPs are getting better and better at just screening for celiac disease when people have the typical symptoms. But in adults, the most common extraintestinal manifestation of celiac disease is iron deficiency anemia due to poor nutrient absorption. But in kids, it's short stature. And so there are different presentations in adulthood versus childhood. There's also a significant proportion of kids with celiac disease that have hypoplasia of their dental enamel. So that's like colored spots on their teeth. Usually not just one isolated spot, it's usually on multiple baby teeth and in various areas of the tooth. And amongst our psychiatric patients, so there's a really high prevalence of mood and anxiety disorders in patients who have celiac disease compared to controls. And these are population-based studies. They don't look at adherence to gluten-free diet. They're really looking at, does this person have a CD diagnosis over their lifetime, and found that they really do have higher prevalence of mood and anxiety disorders. So it's hard to tell whether or not actually adhering closely to the gluten-free diet is protective, but it seems that there is some, also there's a significant proportion of people who have celiac disease who are not the most adherent to the gluten-free diet as well. But anyways, 30% of people with celiac disease have major depression, 18.3% with panic disorder, and 4.3% with bipolar disorder. So really elevated rates of these mental disorders in people with celiac disease. One study did show that even after the patients had adhered to a gluten-free diet, they still had higher levels of anxiety compared to population controls. In children, there are higher rates of parent-scored anxiety. Also, to a lesser extent, but this is also statistically significant, and that is higher rates of disruptive behavior. And it's estimated that 5 to 10% of pediatric patients with celiac disease have anxiety and depression. So much higher rates than even in the regular population. And so you can imagine that people who are coming to see psychiatrists might have higher prevalence of celiac disease than the general population as well. So screening for celiac disease is pretty straightforward from the psychiatry perspective. You look at the symptoms, you check family history and medical history, and if the patient has risk factors, then you just order a lab, and beyond that goes to a GI referral. That's kind of the nutshell. So the family history is anybody who has a first-degree relative of somebody with celiac disease needs to be at least symptomatically, like review of systems, screened for celiac disease. And that would be, there are a lot of people who have a first-degree relative with celiac disease who also are going to have celiac disease themselves. So, and 66% of those patients will have atypical symptoms, and almost 30% of them are totally asymptomatic. And so the asymptomatic first-degree family members of somebody who has celiac disease have a 7.5% risk of getting celiac disease themselves. And then of those people, 30% almost are going to be asymptomatic. So anybody with a first-degree relative, we should be looking, and I've been starting to ask my patients, like, is there a family history of celiac disease? Okay, in whom? And that's a starting place. And then anybody with medical history, a lot of times the core autoimmune conditions, autoimmune thyroiditis, type 1 diabetes, autoimmune liver disease, people with selective IgA deficiency should all be screened for celiac disease due to the high prevalence. And then people with the HLA, DQ, and D8 genotypes, as well as people with trisomy 21, Turner syndrome, should all have celiac disease screening. And that's recommended by the GI Society, both of them. So to screen for them, you order a tissue transglutaminase 2 IgA antibody, and plus a total serum IgA level. And the reason you have to do the total serum IgA level is because you want to make sure that there's enough IgA in the serum to interpret the results accurately. In other words, that the patient doesn't have a hidden IgA deficiency. If a person has an IgA deficiency, you should order the deamidated gliadin peptide. And then there used to be screening using the endomysial antibody EMA, but that's not routinely recommended anymore for screening purposes, just because it's pretty labor intensive and can be technician dependent on how it is interpreted. So sometimes that can be used as a confirmatory lab because it has really high specificity. And we'll talk about that in a second. But the other thing to make sure is when you're screening for celiac disease and you're getting the labs, make sure that the patient isn't already gluten-free, because if they are, that means that we might not be able to pick up if there are antibodies. So somebody needs to be consistently eating gluten for 1 to 3 months. So somebody with an elevated TTG IgA level is probably going to have celiac disease, and especially if it's 10 times above the upper cutoff level, that's a pretty good prediction that they really do have celiac disease. And there has been some debate, especially in kids, about whether or not it's a GI doctor really needs to do a confirmatory EGD for the biopsy if they have an elevated level that much, and especially if they have endomysial antibodies. Then you can just put them on a gluten-free diet and diagnose them with celiac disease without having to get the biopsy, but that's still something that's really controversial. Some will do that and others won't. It depends on where you are in the world, really. But especially in adults, the positive TTG IgA levels, just as a psychiatrist, you just refer them to a GI doctor, and the GI doctor is going to want to do a confirmatory duodenal biopsy. So the recommending gluten-free diets to people, there's a quick acronym, it's BROW, B-R-O-W, barley, rye, oats, and wheat. Those are the main things that need to be avoided. There are all kinds of sources of hidden gluten in food products, and that's kind of beyond the scope of what we're talking about. There's controversy about whether people with celiac disease can eat oats or not, and whether if the oats were made on a dedicated gluten-free line, if that would be okay. And then again, it can be really hard to transition to a gluten-free diet, especially for kids. And sometimes referral to a nutritionist is important. And it's important also to recommend that, somebody has to be going gluten-free for a long time in order to get the benefits of healing up in the intestinal mucosa. It can take even 1 to 2 years for things to heal. And we know that the intestinal symptoms of the diarrhea and the malabsorption and that kind of stuff improves actually quite a bit faster than the extra intestinal symptoms, which would include the cognitive stuff, the the arthralgias and the rashes and those kinds of things. And there's just a quick thing here about Tourettes Syndrome and gluten-free diet. There was a pilot study, so no control group, but it was done in 2018 looking at 26 kids and 8 adults who had Tourettes Syndrome, many of whom had comorbid OCD. A fair amount of them, and the kids and 100% of the adults, were on psychotropics. And they were followed for a year of a gluten-free diet, and most of the patients actually completed the study successfully. And all of the results were significant. It was amazing that they found that motor tics were reduced, vocal tics were reduced, and these are using standardized questionnaires. OCD symptoms improved, the quality of life improved, psychotropic consumption reduced, and participants enjoyed fewer respiratory infections, headaches, rashes, and sleep disorders. So, the tics were more important, like they improved more in kids who had in the kids who were gluten-free compared to the adults, but you can see that there are some places where the adults actually improved more, such as the adults were able to wean off of some of their psychotropic medication even more than the kids. So something to think about for patients who have Tourette's syndrome going gluten-free. Questions?